My extreme pleasure to introduce our guest speaker, Dr. Ernest Gonzales. Dr. Gonzales is the James Weldon Johnson Professor of Social Work and Associate Professor, the Director of the MSW Program, and the Director of the Center for Health and Aging Innovation at NYU Silver School of Social Work. Dr. Gonzales is an expert in the areas of productive aging, equity, discrimination, intergenerational scholarship, and social policy. His research advances our understanding of social structures that optimize the ability to live a long, healthy, and meaningful life. Dr. Gonzales has received funding from the National Institute on Minority Health and Health Disparities, the National Institute on Aging, the U.S. Social Security Administration, the AARP Foundation, the Eisner Foundation, and many other federal, private, and local sources. For today's presentation, Dr. Gonzales will be presenting Promoting a Long, Healthy, and Productive Life for Everyone, Opportunities in the 21st Century. Without further ado, please welcome Dr. Gonzales.
Thank you, Dr. Manuel and Dean Manuel. It's so great to join you this afternoon in Connecticut. And it's a complete honor to meet you all virtually. I would prefer if we just be rather informal. So if you have a question at any point, put it in the chat and hopefully I'll see it or someone will bring it to my attention. And you're more than welcome just to unmute yourself and ask the question or make a comment for sure. Many of you are probably wondering who's behind me. That is Dunkel. She's our standard poodle for 13 years now, and she's just a love bug of mine. There are going to be a couple of studies that I want to share with you at a very high level. And if you want some details about the methods and the measures and the statistical approach, go ahead and take your phones out and just follow that QR code. And that will take you to my center and all the publications that we have been releasing over the couple of years. We launched it in 2021. So a couple of readings there. Let me go here. Especially during COVID, I am so passionate about ending ageism, and during COVID held many webinars on how to do that. And every webinar kind of recruited about 600 folks. It was impressive to see the hunger, the desire among gerontologists, public health, social workers, economists, and just the general public wanting to know how the heck can we end ageism. And during one point, I also, so I would say we have to end ageism, and a lot of positive response, high levels of enthusiasm was expressed in the chat. And then I followed up one time and I said, and we must also end racism. And oddly enough, the enthusiasm, the volume of it was not as high. And I'm not too sure exactly how to explain that. So I followed up again and said, and we must end sexism. And sure enough, my colleagues who are feminist and gerontologists, they riled up again and said, absolutely. And just attending the Gerontological Society of America for over the past 2 decades, and in those instances, I have been constantly reminded that as gerontologists, we are so passionate about aging and ageism, but we haven't really adopted an intersectional approach to end prejudice writ large in many of its facets. And so one of the take-home messages that I hope you'll think about is Dr. Martin Luther King's statement, injustice anywhere is a threat to justice everywhere. The second thing is, as I talk about ageism and it intersects with other forms of oppression across ecological frameworks, there's an opportunity for you to see that we actually have a lot in common across age, across race and ethnicity, across gender, sexual identities. There's a lot that we have in common. And so later on, later in your day, when you're jogging or in your garden or making dinner, I hope that you reflect on how we together in concert could move the needle closer to equity through your research, through your practice, through your policy advocacy, and through your education. To accomplish those take-home messages, I'm going to review about 5, 6, there might even be 7 studies that I review at a very high level. The first bundle really is focused on ageism within the workplace, that it's inclusive, covert, and harmful to health and occupational well-being. The second or the third study that I'll be sharing really adopts a critical race theory perspective, cumulative advantage, disadvantage, to understand how we could build the capacity to work longer across race and ethnicity. And the last couple of studies really are a rebuke about no data, no problem, and missed opportunities to really interrogate heterogeneity within a very diverse society. We'll open it up for questions and comments at the end. As many of you know, we are living longer than we have ever in the history of humankind. And prior to COVID, there was a study that suggested half of the children that are born today will live to be 100 years of age, if not older. And even though life expectancy took a ding during the pandemic, it is trekking right back up. And epidemiologists are in general agreement that we are on track to live longer at rates prior to COVID. Often, when we think about aging and older adults, a number of words that start with the letter D come to mind. Most recently, in fact, it was about this time last year that I was at the World Bank and we were debating paradigms on aging. And we had economists and doctors who were, my opposing team on this debate, and they characterize older adults with words that start with I, and there were 4 words: impotence, incontinence, incompetence, and illness. And that tone, that approach to aging is really a deficits perspective. And when we adopt that internally, we really start asking questions through a deficits perspective. The productive aging framework is juxtaposed to that. It sees older adults as assets, as valuable members to society. It sees aging as an opportunity, as a blessing. This strengths-based approach to aging results in different research questions than a deficits perspective. And one of the questions that I've been kind of ruminating on for the past 5 years has been, how can we all live a long, healthy life with a solid economic foundation, strong social bonds with family, friends, and community, and in a diverse, dare I even say, loving and peaceful society? So I argue that to answer that question, a productive, equitable aging perspective is needed, and I'll show you how after this presentation. So we get asked questions many times, what the heck is productive aging? And there are many ways to define it. I've adopted a rather conservative approach, predominantly because you need to put some boundaries on social phenomenon for research, for policy, for practice. And so I've adopted Bass-Caro and Chen's definition back in 1993, any activity by an older individual that contributes to the production of goods or services, whether paid for or not, and narrowed it down to employment, formal volunteering, and caregiving. We could have ongoing debates as to whether gardening counts and whether attending Shakespeare classes count. So if you have any questions about that, we could most certainly circle back to it. But for the purposes of today, I'm really actually just going to focus on employment. During COVID as well, I participated in generating a consensus report on work and retirement for the National Academies of Sciences, and this is what we produced. It's pretty much summarizing all the research to date on gaps of what we don't know about work and retirement in later life and what we do know. And this committee was transdisciplinary. I was the only social worker on it, but we had economists and psychologists, sociologists, some feminists as well. And there is a big kind of philosophical debate about how we promote working longer. This image here of carrots and sticks, it's my attempt to summarize the debates that I had with economists on that committee. And generally, we have many policies that have adopted a carrots and sticks approach. So for Social Security, for example, in retirement, if an individual claims early retirement before their normal retirement age, there's a reduction in the monthly retirement check that they would receive for the rest of their life. If individuals retire at their normal retirement age, then they would receive 100% of what they're due. If individuals delay claiming Social Security retirement by 1 year, there's an 8% increase of a bonus all the way up to the year of 70. Pretty nice, right? But you can see in this social policy context that there are some carrots to delay retirement, and there are sticks if you claim early retirement. And I really perceive that as problematic because individuals that can delay claiming Social Security retirement already have a number of carrots. And those that need to retire because of health, because of discrimination, because of other forms, because of caregiving, they experience the stick. So productive aging does not adopt that carrot and stick model. Rather, we really adopt a person and environment perspective. Here, we really emphasize that if we want to promote working longer and delaying retirement, that we must build the capacity across the micro to macro continuum across one's lifespan. That is a message that what we don't say is pull yourself up by your own bootstraps. That's what economists say. We say focus on the environment. How can we promote health? How can we promote choice and opportunity within neighborhoods, within organizations? How can we make work and work environments rewarding, psychologically, physically, spiritually rewarding to lead to some outcomes at the individual, family, neighborhood, and at the societal levels? So the productive aging framework really rebukes the carrots and stick approach to retirement. Within this area of research, it's fraught. There's a tension of principles. Without careful analysis and reflection, we could easily slip into a narrative that working later is an elitist movement, that it's an obligation. It could also fuel conflict between generations, and it could add constraints to individuals that already have a number of constraints on them. As opposed to, principles of inclusion, of opportunity, adopting an anti-ageist, anti-racist, anti-sexist, anti-oppressive perspective, really promoting intergenerational harmony and choice. So there's that tension within this area of research. Under optimal conditions, you can see and expect many positive outcomes at the individual all the way to society level. Throughout this presentation, we'll really focus on mental and cognitive health, and you'll see pretty soon the benefits to society. But here's just a couple of quick facts. Older adults that volunteer saves our nation about $78 billion a year. Older folks that are caring for family members and friends saves our nation anywhere between $100 to $500 billion a year, depending on how you measure caregiving. So these positive outcomes can really be maximized. All right, let's get to the first set of studies that age discrimination at work within the workplace is inclusive, covert, and harmful. AARP a couple of years ago released a study indicating that older folks, 50 years of age and older, contributed approximately $6 trillion through the work environment and the production of goods and services. This was a 40% increase in GDP, pretty significant. And on the flip side, for those folks who had the health and the time to work, but were experiencing barriers to employment, it cost us, the nation, $850 billion lost in GDP. So ageism is quite expensive. A colleague of mine, Lisa Marchiondo, in New Mexico, we had just completed our PhDs, and she was at Michigan and I was in St. Louis. And we, even back then, were quite passionate about ageism. And one time we were just drinking some wine and having dinner, and we thought, you know, what's missing in the literature is a measure that captures covert discrimination. Yes, you know, age discrimination in employment, it was really about the big kind of like blatant forms of discrimination, not getting hired, promoted, being fired. But what about the everyday microaggressions? There wasn't a measure that really captured that. We also wanted to problematize and challenge that it's not just older adults that experience ageism, but practically everyone of every working age. And we really wanted to see, how does the distribution of being a target of ageism vary across the working lifespan? We also wanted to see how it may have a disproportionate impact on minoritized individuals, women, racial ethnic minorities, folks with lower levels of education, and whether that was associated with health and occupational well-being and retirement and turnover. So we sought out, and it's a mixed methods approach, and if you want, I'll send this to you all, and you could tap that link and really see the study. Initially, we did a qualitative analysis of 200 individuals. We just asked to tell us in great detail how you believe you are discriminated against because of your age. We culminated all of that data and then subsequently surveyed about 1,200 folks through Amazon MTurk who were working 40 hours or more and who were 18 years and older. And we really whittled this measurement to WADS, the Workplace Age Discrimination Scale. And high validity, reliability, the psychometric properties to this instrument is pretty impressive. And so we asked, please indicate how often you've experienced the following at work. I feel as though I've been treated as though I am less capable. I've been given fewer opportunities, been unfairly evaluated, passed over, received less support, et cetera, all because of my age. So we really tie it to age here. And as you can see, younger emerging professionals reported being a target of ageism at similar, if not at higher rates than older adults. So across the entire working lifespan, individuals are being targeted on ageism, with younger and older folks being even more so than middle-aged individuals. Using structural equation modeling, we tested the relationship with job satisfaction and organizational commitment. And in the expected directions were the results. Being a target of ageism led to job dissatisfaction, reduced organizational commitment, a higher intention to leave the organization, and worse mental health. To unpack heterogeneity, we looked at variation by age and race and ethnicity. And here we found an interaction effect where higher levels of ageism led to a decrease in organizational commitment across all ages, but this was more, had a larger effect on older workers compared to younger and middle-aged workers. Higher levels of ageism led to worse mental health. And again, we see an interaction effect where this had a disproportionate impact, more so on older folks than it did on younger and average aged individuals. We looked across Hispanics, Asians, Blacks, and whites, and there was no difference in being a target of ageism and worse and lower job satisfaction among Hispanics, whites, and Blacks. So we lumped them all into one group. But we did find that Asians were less affected by ageism with their job satisfaction compared to those racial ethnic minority groups. And this, keep in mind, was before Trump, it was before COVID, and it was before really the the racism on Asians really became inflamed. So if we were to capture survey data all over again, I would expect there's no difference across race and ethnicity, that actually there would be similar levels of job dissatisfaction, even among Asians. That study was cross-sectional, so it had, its limitations. But we dived into a longitudinal representative sample of older adults, and we essentially asked the same questions, but with a longitudinal design. And the results were confirming that age discrimination led to depression, worse self-rated health, job dissatisfaction. Unlike our cross-sectional study, however, there was no effect on when people retired. All right, so that informed another study. Here, I was really interested in differences of retirement across race and ethnicity, specifically focusing on whites, Hispanics, and Blacks in the United States. And while ageism at the workplace was quite evident, I wanted to look at other ecological domains, neighborhood characteristics, given redlining and structural racism, major experiences of discrimination, and everyday discrimination outside of the workplace. So how does this cumulative disadvantage, for which we know really disproportionately affects racial ethnic minorities, how does this affect mental health? And does it actually inform early retirement? So dived into the health and retirement study again from 2008 to 2014. Here is about 1,000 folks that I analyzed. The dependent variable retirement age is quite slippery. It's very difficult to actually measure retirement age. Many of you may actually go to Home Depot and other places, and you'll see older folks who say they're retired and yet they're working part-time. So it's a very, we have retirees that say that they're not retired or unretired, or they're on their fourth retirement. So operationalizing retirement age is really quite slippery, and happy to go into great detail if you have any questions about that. But I really looked at how everyday discrimination, chronic workplace discrimination, neighborhoods, et cetera, related to health and retirement, while controlling for factors that we know are predictive of retirement age. To give you a flavor of major lifetime discrimination, this is what respondents reply to. And at any time in your life, have you been unfairly dismissed from a job, not hired, denied promotion, prevented from moving into a neighborhood, unfairly denied a bank loan? How about this? unfairly stopped, searched, questioned, physically threatened, or abused by police, unfairly denied health care or treatment. So, pretty major events of resource hoarding here and unfair treatment. Neighborhood characteristics really fell into two buckets: social cohesion and the built environment. Workplace discrimination, similar to WADS, the measurement that we created. Within the last year, how often are you unfairly given tasks at work that nobody else wants to do, watched more closely? You feel like you've been ignored or not taken serious by your boss. Co-workers or supervisors making slurs, jokes about women or racial ethnic groups. Everyday discrimination in your everyday day-to-day life. How often have any of these happened to you? Treated with less courtesy, poor service at restaurants or stores. People think you're not smart. Folks are afraid of you, threatened or harassed. Receive poor service from doctors or at hospitals. We stratified all those responses by race and ethnicity, and I'm going to walk you through very carefully differences by race and ethnicity. So Hispanics reported living in neighborhoods with more that were physically chaotic and disordered, followed by Blacks, then whites. Blacks reported the highest level of living in neighborhoods of social incohesion, followed by Hispanics, then whites. Major lifetime discrimination. Blacks, half of them reported these experiences, the highest level there, compared to Hispanics at whites, similar levels. Interestingly, work discrimination. Whites reported the highest level of work discrimination, 7 out of 10, compared to Blacks and Hispanics. Again, everyday discrimination. Whites, 8 out of 10, reported the everyday discrimination, highest level compared to Blacks and Hispanics. We ultimately combined a cumulative disadvantage scale, so across these measures, and it had an internal alpha of 0.76, pretty good. And you can see on the right, Blacks overwhelmingly experience cumulative disadvantages compared to whites and Hispanics. Out of all of those measures, only one, everyday discrimination, asked, why do you think you were discriminated against? The attribution, right? And among the entire sample, ageism was the number one reason, followed by because of their gender, their weight, race, physical appearance, ancestry, physical disability, and sexual orientation. So a lot of intersectionality material here. Stratified by race and ethnicity, Blacks reported the highest level of racism, right? So why do you think you're discriminated? Because of race. Second reason, and by far, was age. And you can see the other attributes there. Hispanics and whites reported it was because of ageism predominantly. And then after that, among Hispanics, it was because of race, ancestry, physical appearance, gender, and weight. And among whites, you can see ageism as number one, race being very last, only 2%. But here's an opportunity for DEI officers within employment contexts to really identify common ground among employees by age, by race, by ethnicity, as well as unique characteristics in which caution on how to approach it. So implications for DEI here. Going back to the initial research questions, mental health fully mediated the relationship between everyday discrimination and retirement age, as opposed to major lifetime neighborhood characteristics and work discrimination had a direct effect on retirement, as well as operated through mental health. Surprisingly, going back to cumulative advantage, disadvantage, there was no difference in retirement age by race and ethnicity, meaning that whites who were just as disadvantaged as Blacks and Hispanics, they retired at similar ages, 62, early retirement, as early as you can get it, 62. Those who were advantaged, whites, Blacks, and Hispanics, they all retired much later, and for this cohort, they retired at their normal retirement age, 65. Shifting gears a bit, many of you are gerontologists or studying aging, and I've been a little disturbed by, research that really doesn't examine race and ethnicity, doesn't interrogate heterogeneity. And it really goes back to the old adage, no data, no problem. And I think that's a problem. And I'll show you why. We know that Blacks and Hispanics are at greater risk of cognitive impairment in later life compared to whites. Cognitive impairment is problematic writ large for everyone. And so finding opportunities to delay the onset as well as the severity is a major research agenda that I have going on right now. We know from Livingston and her team, both in 2017 and 2020, they did a systematic review identifying that a third of dementia cases could be prevented altogether, right? Hear me, could be prevented altogether. And we know for sure that there's a genetic inheritance in here, right? So APOE and a couple of other biomarkers, we know that there's an influence there. But environmental factors, such as education being a constant predictor to cognitive functioning, and then in midlife, hearing loss, hypertension, obesity, and later in life, smoking, depression, physical inactivity, social isolation, and diabetes, all of that we can control. We can create interventions. We could prevent the onset of Alzheimer's. What we really haven't examined to a great extent is how work complexity, if education is such a strong predictor of cognitive health, well, one would automatically assume that the work we do, which is highly related to the quality of education, would also have the capacity to build a healthy brain, new neurons through doing complex tasks, novel tasks. Similarly, volunteering in later life, that's very similar to work. So the logic is, how does volunteering protect our cognitive health? And what, for me, at least, I was really concerned of how is race and ethnicity problematized, conceptualized, examined in this growing area of research. So we undertook a scoping review. I'll save you many details, happy to talk about them during Q&A. But we collected fewer than 5,000 articles. And given our inclusion criteria, we had 107 articles that we analyzed. Out of 107 articles, 22 of those empirical studies had race and ethnicity as controls. Out of that 22, only 7 had any meaningful discussion on race and ethnicity. So what did we learn? How can we explain that? Many of the articles in this scholarship really relied on environmental and occupational complexity and cognitive reserve hypotheses. So Cohn, Schuler, and Stern, their theoretical frameworks didn't even didn't acknowledge social stratification. Cohn and Schuler in 1983, they were really coming out of the civil rights movement. So it's a little bewildering to think that coming out of the civil rights movement and as social scientists, at any rate, I don't know how to explain it, but these theories just don't interrogate race and ethnicity. It wasn't until this century that we have BIPOC scholars in 2017, 2020, 2021 who introduced the idea of a racial disparity perspective, the productive aging, health equity perspective, and minority poverty framework and diminishing returns hypothesis. It was because of these scholars that we actually have some studies on the relationship between work complexity and cognitive health. And how can I summarize it? That relationship appears to be nonlinear in the context of race, ethnicity, and gender. So here are a couple of results. This is a study that I did with a colleague, Jane Lee, who's in Hawaii. We looked at mental demands, social demands, and physical demands of work. And mental and social were positively associated with cognitive functioning in later life. Mental demands, Blacks, their cognitive health was very much affected by mental demands. Social demands, it was men and higher educated folks that their cognitive health was really beneficial from the social complexity of work. Across the board, physically demanding work doesn't help your brain. And more importantly, had a disproportionate effect on Hispanics. This is Hayun. She looked at Blacks and whites and occupational complexity. And in her study, she found that it was African Americans with the lowest occupational complexity that had the highest risk of developing dementia compared to whites. Fuji Shiro, love her. She came out with this study in 2020. She looked at whites and Blacks, men and women, and education. And essentially, her study summarized that the hypothesis that complex work will help build a healthy brain and delay cognitive impairment, that was true for white men. Not true for women of Black or white women. And it wasn't true, and that hypothesis turned out not to be true among Blacks, both genders, as she operationalized it. And so there's this diminishing returns that still is a research question for the field. And that's actually going to be an R that I'm submitting June 5th of this summer. I'm really interested in how this cognitive inequities by race and gender in the context of work. And so we have the opportunity with the health and retirement study to look at not just Hispanics, Blacks, and whites, but also indigenous folks. My doctoral student, some of you may know him, Cliff Watang, just defended his dissertation Monday, and he's now going to be faculty in Minnesota, Duluth. And so he's going to be part of this R. And Jane, a colleague of mine who's in Hawaii, she's going to be on this R as well. So we're going to take a look among Hispanics, Asians, Indigenous, Black, and whites with occupational complexity. And I suspect that related to the earlier studies, these workplace discrimination, these neighborhood characteristics, maybe that explains why women and racial ethnic minorities do not gain the same cognitive benefits as white men. So to be determined. The productive aging perspective has gained attention by senators. In fact, April 20th of last year, I provided testimony on age discrimination laws in the United States. And I thought it was a one and done. I thought, just go testify, it's done. But the senators came back with all sorts of questions many, many weeks later. And they were not just interested in ageism, they were interested in paid leave, in the Caregiving Credit Act, and how do we build equitable saving vehicles for retirement for everyone. And so this productive aging research really has the attention of senators in Congress, and it's grabbed the attention of the national academies at the World Bank and at the UN. Interesting enough, just a quick factoid, we're not the only country that's experiencing extended longevity. And our retirement system was really based on Otto von Bismarck back in Germany in 1887. And essentially, in Germany during that time, many Germans were fleeing to the United States, new American land to become landowners. And as a consequence, German German folks were leaving, and Otto von Bismarck needed them to stay in the country to build roads and banks and all sorts of buildings. So he made a deal with Germans in 1887. He essentially said, if you stay in Germany and help build it, we will promise you a retirement check. We will promise you unemployment in case there, when the economy booms and it busts, we got your back. If you experience, a disability on work, we'll give you disability insurance. Well, we adopted those policies wholesale during the Great Depression, and we were not the only ones. Practically every other country has that model of retirement and work. The problem is that in Germany in 1887, very few people were living to the age of 65. So, Otto von Bismarck was kind of clever, I suppose, maybe not very generous in the end, by saying if you lived to a certain age, you could retire, and we got your back. Now, us and across the globe, we're living much longer. We might have 30, 40 years of living on retirement on a system that is a pay-as-you-go system. So Social Security is at risk, not just in the United States, but globally. So it's really caught the attention of the UN and the World Bank of how do you promote, with a compassionate lens, the opportunities, the choice to work longer. So if any of you would like to join my team, please join. All right, so quick summary, so then we can have some questions and comments. I also know that folks online may only have an hour for lunch, so you might have to leave at 1. But a quick summary, structural and interpersonal discrimination, disadvantage undermines health and capacity to work longer. And we see that by whites, Blacks, and Hispanics. We also see that our research is not inclusive, nor is our policies and our practice. So we certainly need to apply an intersectional health equity lens to productive aging. Ongoing hypotheses about work and volunteer complexity as determinants to cognitive health. And we just really need a lot of interventions from micro to macro. And here's just a couple of ideas. At the micro level, Gordon and Alport's contact hypothesis is pretty outstanding, right? We have used that theoretical framework to undo ageism, and others have done it with undoing racism and ethnocentrism and bias on sexual and gender minorities. What we haven't done is applied an intersectional lens to do 2 isms or more isms at once. So that's a point for further research. DEI, Nancy Moorhow in St. Louis just completed a study. She surveyed large organizations and DEI officers. Only 8% included age as a diversity factor in their DEI efforts. Hopefully the data from Health and Retirement Study could help build that area of research. I also hope that many of you who are social workers feel inspired to know that mental health either partially or fully mediated the relationship between discrimination and disadvantage and retirement. Mental health is our wheelhouse, right? It's not in nursing, it's not the economists, it's social work. We know how to bolster mental health. So we need to start building those programs within work environments to improve health in order to work longer and delay retirement. At the macro level, there are a couple of federal policies that I point out here that need to be passed, and hopefully will do so with this Congress, and I'll leave it at that. A quick shout out to my research colleagues and to funders. They are such a great team, and couldn't do it without them. So with that, let's open it up for some questions and comments, and let's just engage in conversation.
Amazing. Thank you, Dr. Gonzalez. I'm going to monitor the chat.
Okay.
And I believe attendees can unmute themselves. So please feel free to do that or ask questions in the chat. But while we're waiting, I just want to thank you so much, Dr. Gonzalez, for that really amazing presentation.
Yeah, my pleasure, my honor.
Yeah.
It always takes some time for questions to filter in.
Yes.
Yeah. And to let folks know, I have thick skin. So if you want to critique anything that I've done, please do so. I learn from it. So
Yeah.
always happy to hear some critique.
Well, I have a question that will
Yeah.
maybe help us get started. We've been thinking here about how to increase student engagement in the area of aging and gerontology. And so the Scholars in Aging program has helped to do that to some extent. But I'm wondering if you have ideas on on how to engage students in this important work.
Yeah. All right. Let's see. In 2007, Judith Salerno was a program officer at the National Institute on Aging. And she hypothesized that we don't have enough, she knew we don't have enough doctors, geriatricians for an aging society. In 2007, we needed 40,000 geriatricians. And in fact, we only had 7,000 of them. Now the demand has grown even more so, and we have fewer and fewer geriatricians. And so she hypothesized it's because of ageism. Well, we created a whole intervention among medical students, and we were able to undo and disentangle medical students' assumptions on age. In fact, we did a qualitative, quantitative approach. And I remember this one student saying, prior to this intervention, if I had a client that came to me who was 72, female, white, complaining about pain in her elbow, I would have automatically assumed it was arthritis. But I met Betty in this intervention, and I learned that Betty loves to play tennis. And even though both of her elbows are the same age, she only has problems with the elbow in which she uses to play tennis. It's tennis elbow. Her point was that you got to see the client not based on your assumptions. And so that patient-centered approach is really what we should be doing across medicine, nursing, social work, psychology. You got to see the person in front of you and be aware of your biases. Even though the student had negative assumptions, there are positive assumptions that could be just as detrimental. If we think older adults are capable and competent and reliable, we may not take time to break down which medication to take, how to take it. Rather, we could assume that, oh, you know, Betty, she knows how to read labels. I don't need to talk to her about medication adherence. No, even a positive assumption. So I'm trying to get my students to a very neutral approach to understanding age, positive or negative. We all have them. Just recognize it and into your practice. It's that I think we need. But to attract students, followed up with qualitative, we assessed pre-post, it was a quasi-experimental design. We asked students, do you plan to go into geriatrics? And we tested whether that changed after the interview. No one changed their career path, no one. So I remember traveling to Dallas and Pittsburgh and a couple of other places to do some focus groups. And time again, they said, listen, we see the writing on the wall. there's such huge demand for geriatricians that they don't get paid well, difficult for reimbursement, and they don't have any work-family balance. Count me out. And so it's these structural sort of changes that we need in order to recruit students into it. An ongoing hypothesis has been, as NYU Medical School went tuition free, a big question is, are these students going to go into practice in rather low paying, difficult medical fields? So to be determined, that's to forgive student debt. That's one working hypothesis. The other thing that we've done, when I launched the center a year later, we launched a healthy aging specialization. And we surveyed the US to see who's done it, how have they done it. And we learned that we really tell students, you got to make a choice. It's an or. Is it children, youth, and family, or older adults? That's not healthy. That's not healthy for a diverse society. It's not healthy for the practice. We need to do an and. How can we focus on older adults and younger folks? Really take that lifespan approach. Go deep in it. Trauma-informed therapy with two different generations at the same time. We have gotten stuck in an age siloed society that we got to undo that. And I think the way we teach our students is one of the ways we undo an age segregated society. So I think those are some ideas there.
Thank you. Those are really important points. And we do have some questions that have populated in the chat, so I will read those from Brianna Bish, who's one of our doctoral candidates here
Yeah.
at the School of Social Work. Can you talk more about research regarding LGBTQ plus folks and ageism? You talked about how there is such a lack of data on race, and there seems to be even more lack for this minoritized population. How can we engage researchers on this important work?
Fabulous question. It's a great observation. And how do I insert a link here? I'm sure there's a chat feature that I could.
There, yeah.
Yeah, so let's see.
It's the bubble on the bottom right.
Okay, let's see. Nope, found it. Thrilled. I share your concern. When I was in St. Louis in the Ph.D. program, we launched SAGE, which is an organization for sexual gender minorities. It's been around since the 1970s. We certainly, it's the major place, its home base is in New York City, but we certainly saw the need in St. Louis, and so we opened up a chapter. But we subsequently, Karen Friedrichsen Goldstein at the University of Washington has received many grants from the National Institute on Aging to collect longitudinal representative sample on sexual gender minorities in later life. So her team is constantly expanding. They're doing some really innovative work. I would point you in that direction. She and her team are wonderful colleagues. So, I'm cheering you on for sure. But with regard to ageism and sexual gender minorities, I really don't know. I don't know. In the data that I have access to with the HRS, in 2006, only 1% of 1,000 people had reported bias because of their orientation. So very small number. It's increasing over time. So when we looked at data in 2020, I believe there was like 6%, and the sample there was about like 32,000 people. So there should be enough data in the health and retirement study cross-sectionally to understand and characterize that sample social economic conditions. But I really don't know, to tell you the truth. I could only speculative, double, triple jeopardy hypothesis, having two or more minority identities. And it's an interesting result. There's some evidence to suggest if you really have like three minoritized identities, you actually have more resilience to overcome interpersonal and structural discrimination because you've been there to the rodeo many times in your life. Suicide rates among older adults, the biggest population at risk for suicide is white men who have a gun. And it's kind of perplexing. And the only way to give it an answer to why is that the case, white men have for most of their lifetimes experienced privilege. And it's not until their later lives that they actually say, I feel invisible. I'm not being seen. I'm not being, I'm experiencing discrimination here, and they don't know how to deal with it. Combine that with some social isolation and other issues, and then access to a gun, suicide rates are quite high. But fascinating question. Sorry, I couldn't give you
Yeah,
a fuller answer.
great.
Yeah.
Thank you. So we have another question from Dr. Lisa Workmeister Rosas, who's
No.
a professor here at the School of Social Work. I had one question about Alport's contact hypothesis. Much of the research done with this theory talks about its limitations based on the various conditions that have to be applied for positive contact to occur, much of which is difficult outside of a controlled lab. What are your methods around this?
I know it's so difficult. So just for others in the audience, the conditions that I'm aware of is you bring the in group in contact with the out group. They have equal status, challenging. They engaged in a shared activity. That activity is praised by a higher authority, and the out group cannot be indicative of the stereotype. All right, so those are a lot of conditions, geez Louise. And some colleagues up at Columbia released an article in 2019. It was somewhat of a systematic review, although not rigorously done as such. And they identified 13 articles out of about 80,000 articles that have reported Gordon Alport's conditions. It's still not clear if all 5 of these conditions are necessary to undo an assumption. And so that program that I talked about with medical students, it was replicated at the University of Virginia. And actually it was VCU, is that Virginia Commonwealth University? Yeah, VCU.
That's right.
And what was so fascinating with their program was that they brought medical students, social workers, physical therapists, nursing students in contact with older adults that had a variety of health capacity. And they brought them into a dance program where they created choreography together. That was the shared equal activity. But what was unusual was that the older adults actually had a limitation, a physical limitation. They didn't do a quantitative analysis on whether it undid any bias. And keep in mind, there are like 3 latent constructs that we should probably measure. What are my assumptions about Hispanics, let's say, on their mental acuity, their social interaction, and their physical capacity? So there are these 3 latent constructs that need to be measured. I suspect in that VCU intervention, mental for sure probably changed, social for sure, but we don't know about physical. And it was because of that principle that they can't be indicative of a stereotype. So to be determined, I'm doing a study now analyzing how many of these contact hypotheses studies have actually taken ageism and racism or 2isms at once. Spoiler alert, at the moment, no study has done that today. So to be determined.
Okay. Thank you. Let's see. I think oh, so we have another question. Actually, another comment from Brianna that I'll just read. I'm actually finding folks in my dissertation project on LGBTQ plus older adults do have a lot of resiliency and positivity about their aging and health. So I definitely agree they are very resilient population. Maybe I will have more answers after my project and will let you know. And Dr. Fredrickson Goldson is great. She has been very helpful anytime I've reached out. Amazing presentation today.
Oh, great,
Um,
Brianna. That's great feedback. One thing to analyze with your respondents, Laura Carstensen, psychologist, Stanford, proposed a theory called socio-emotional selectivity theory. And it's to suggest that when we're younger and in good health, our relationship with time is infinite. And so we take all sorts of crazy risks, we do crazy things. But when there's a health event, regardless of age, and when we approach later life, usually in our 50s, our relationship to time becomes finite. And we really focus on the priorities, and we actually let people go out of our social convoy who are not benefiting us anymore. And we really focus on just a fewer people that are so valuable, so meaningful, but it's a choice. And this is also true with our activities. Sometimes people retire from their career jobs because it's no longer bringing them joy, and they choose something else, career switchers. So there's, the social, economic, there are these like a narrower approach. So when it comes to sexual gender minorities and their resiliency, one ongoing hypothesis is like, is it socio-emotional selectivity at play? Is it their choice to get rid of some hostility and such? How does their social convoy change?
hmm,
I
that's
want to read your dissertation.
such a great question. Yeah. And then Dr. Kelsey Carolyn, who I know you
Yeah.
know. So fascinating presentation all around. I'm curious to hear more about the work you're proposing to follow up on the findings regarding white men benefiting from cognitively stimulating work versus women and BIPOC populations. You mentioned neighborhoods. Can you talk more about that or other factors that you're hoping to look at?
Well, first, Kelsey, it's great to see that you're in the audience, and UConn is so lucky to have you. Um, great question. I, so let me disentangle gender from here. By the way, Kelsey has a fabulous article on gender and cumulative disadvantage that folks should read, and in the workplace. So let me disentangle gender, informed by Kelsey. I think that for women, and it may vary by race and ethnicity given the caregiving demands, I think that women may, so the basic hypothesis here is that a stimulating environment produces new neurons in our mind, in our brain. And those neurons and all of that connectivity will help protect when the onset of damage happens, let's say with Alzheimer's, with plaque, that a brain that has dense neurons would have some compensatory strategies to do recall and executive functioning more so than a brain that is not so dense. Okay, it makes sense. But there is a point of diminishing returns. Perhaps an environment is too stimulating, too complex, that actually individuals, their capacity is overwhelmed by the environmental demands. People shut down, depression happens, social isolation happens. So we have to look at what are those environmental factors among women and by race and color that may actually lead to an environmental press in which they lose resiliency. And how does that vary? So that's with women. With men of color, we have to, I guess, really do some stratified analyses here. Structural racism impacts BIPOC men at a very different way than it does women. And so I think those measures of like interactions with police, with employers, with coworkers, living in disenfranchised neighborhoods, this is resource hoarding. And it's very, and I think it's quite blatant. So for men, is there a point in which, anxiety, depression, these are at elevated rates given those predictors? And that's what's mediating the relationship, stress essentially, with cognitive health. So I think it's that person and environment that we need to take to look at how can we just build healthy, beautiful brains and minds for everyone. Yeah.
That's great. I'm not seeing any more questions. Um, so with that said, I just want to thank you again, Dr. Gonzalez, for a really wonderful and informative talk and conversation, and really a lot of food for thought for students, faculty, and staff here, and really across schools of social work. So it's really exciting work that you're doing, and really happy to
Well,
have you here today.
yeah, thank you for the invitation. It's really been an honor. Know that I'm cheering you on. And if I can be helpful in any way, call me up. Happy to brainstorm even further.
Awesome. Thank you so much.
All
And thank
right.
you everyone for joining us today as well.
Yes, thank you.
So,
All right, Jen, thanks so much.
thanks, Ernest. All
Bye.
right. Big hug.
Big hug. Yes,
Take care.
you too.